Okay, in this lecture, we'll be talking about conditions that involve the spinal cord. All right, and to do that, we need to go through some anatomy, first of all. And so we're just going to use three main pathways, one motor and two sensory, which will be very helpful as we consider different conditions that tend to involve the spinal cord. So let's start with the major upper motor neuron pathway, the cortical spinal tract pathway. I hope you're very familiar with. Okay, recall, we've talked about this pathway, how it originates in the precentral gyrus, actually originates from the postcentral gyrus as well, and even from the pre-central gyrus. But this pathway extends down into the midbrain, through the pons, through the medulla, and of course crosses in the pyramidal decussation at the junction between the medulla and spinal cord. What we're interested in now, as it relates to the cortical spinal tract, is this pathway in the spinal cord. Okay, so we'll leave ourselves a generous area here in the white matter. But the cortical spinal tract travels about in this location, in the posterior lateral aspect of the spinal cord, of course on both sides. And one point that's important when we think about the spinal cord and things that may compress and involve the spinal cord is how these fibers are arranged in the spinal cord. Okay, and basically what we have here, if this is the cervical cord, which I'd need to draw a bigger ventral horn if it really were, but the sacral fibers are lateral, and then we have lumbar, thoracic, and cervical. Okay, one application of this would be if we have a disc or some mass pushing on the spinal cord, we'll notice even if it occurs in the neck area, most of the symptoms occur in the legs. Okay, and there are several reasons for that, but one is just notice here that the lumbosacral fibers are more lateral in distribution. So that may be one reason. Other reason is, we'd have to have a pretty high lesion like at C5 to even involve, to a significant degree, the upper extremities. So most cervical myelopathies affect the lower extremity. Okay, now let's, and then of course these upper motor neurons talk to lower motor neurons at each appropriate level. So if you're moving your hand, okay, that upper motor neuron pathway will travel and talk to the appropriate C8, T1 anterior horn cells, and so on. Okay, so that's our motor pathway. Now let's consider two sensory pathways. So I'm going to label this here as the cortical spinal tract. Okay, remember that our two major sensory pathways are for pain and temperature and vibration and proprioception. All right, so information for pain and temperature comes in. That's supposed to represent the dorsal root ganglion there. Remember, these are small, unmyelinated fibers that cross and then ascend on the opposite side. All right, and so these cross on the opposite side and eventually go up to the VPL of the thalamus and then up to the postcentral gyrus. All right, so if we're just drawing this here, if this is the pain and temperature pathway coming in, recall that first it enters an area called Lissauer's tract and it may ascend for several segments there. Okay, then we have a synapse here in the substantia gelatinosa of the dorsal horn, gray matter, and then things cross over to the opposite side. Okay, and this is known as the spinothalamic tract because it's going from the spinal cord to the thalamus for pain and temperature. Okay, and I'm just going to draw this over here. The spinothalamic tract has the same columnar arrangement as the cortical spinal tract. So the sacral fibers are lateral, then lumbar, then thoracic, and then cervical. And once again, if we have a mass lesion, let's say pushing in the cervical area, typically there's what's called a false localization. So the sensory level, as you take your pen and you march up the back, the sensory level is typically lower than where the lesion typically is. Okay, and again, part of the reason for that is that, notice, the sacral and lumbar fibers are more lateral. The cervical fibers are more medial in the spinothalamic tract. Okay? And then the other pathway here that's involved is sensation for vibration proprioception. So I'll draw another dorsal root ganglion here. Remember, these are the large myelinated fibers. Okay? And that this pathway comes in, does not synapse, ascends. Okay, and we have a synapse in the lower medulla. Recall that's either the nucleus gracilis or nucleus cuneatus, depending on whether we're dealing with the legs or the arms. Okay, and then after the synapse, this crosses over, again going up to the VPL and up to the post-central gyrus. So if we want to add a little anatomy here, after the synapse, the crossing fibers are known as the internal arcuate fibers. And then this pathway here, after the crossover, I'll just put ML for medial lemniscus. Okay, so how does this look here? Well, here we have vibration proprioception, let's say. And remember, there's no synapse here. This goes in to the posterior columns and ascends, same side. Okay, and so we call this area the fasciculus gracilis or cuneatus. And the relationship here is exactly the opposite of what we saw with corticospinal and spinothalamic tract. Okay, so here the sacral fibers were lateral, okay, but in the posterior columns, we actually have the sacral and lumbar fibers medial, and then thoracic and cervical. Okay, so basically below T6, we call it fasciculus gracilis, and above T6 is fasciculus cuneatus. All right, so using these three pathways then, we can make sense out of most of the spinal cord conditions that we're going to talk about. And this will be adding some conditions that we didn't talk about during the second year neuroscience course. Okay, so let's divide spinal cord disorders by certain categories. And first talk about spinal cord conditions that mainly have upper motor neuron findings. Okay, and that's why we use the term myelopathy. Myelopathy refers to the upper motor neuron manifestations that are usually prominent with most things that affect the spinal cord. Okay, so remember, what's upper motor neuron? Brisk reflexes, clonus, spasticity, Babinski, and so on. All right, so compressive myelopathy. Okay, and there are a number of different things that can compress on the spinal cord. Okay, but this is probably the most common type of myelopathy that we deal with. And the major manifestation is spastic weakness. So the spasticity and the weakness is below the level of the lesion. Okay, and so, but depending on where the level of the lesion is, and we had one of our cases here for localization where we talked about a C5 myelopathy, okay, where we typically have a disc that compresses the C5 spinal cord. And so everything below C5, recall, is going to be spastic weakness. All right, so in the hands and in the legs, predominantly we'll have spastic weakness. But remember also that at the level of the lesion, we involve nerve roots, and those are lower motor neurons. Okay, and so I should say that here are the sensory nerve roots. I should draw the motor nerve root coming out here. Okay, this is the lower motor neuron. So if we involve that, patients are going to have weakness, atrophy, loss of reflexes at the level of the lesion. Okay, so everything is spastic below, but at the level of the lesion, we'll have weakness and atrophy of C5 muscles and some sensory changes in the C5 distribution. Now, when something compresses the spinal cord, typically we get edema and swelling throughout the entire spinal cord. And that results in some unique symptoms. When the posterior columns are involved, that results in something known as Lhermitte's sign. And Lhermitte's sign typically occurs if it's in the neck, when the patient flexes their neck and they get just a jolt of electricity that travels down the spine. Okay? When someone has Lhermitte's sign in the context of weakness and sensory changes, that strongly suggests cervical myelopathy with involvement of the posterior columns. And if we tend to just have swelling in half the cord, then patients may have a Brown-Séquard syndrome. Okay, we talked about that in the neurolocalization lecture, so very important you remember what Brown-Séquard syndrome looks like, but that localizes to the spinal cord. Okay, and also, anytime we involve the spinal cord, bowel and bladder symptoms are exceptionally common. Okay, so we want to associate that with spinal cord disorders, and difficulty with maintaining an erection also would certainly be common. So what involves the spinal cord? Well, disc, of course, but also very important, especially if this comes on acutely, we are concerned about metastatic involvement. Okay, and there are a number of things. Metastatic involvement is more likely in the lumbar cord and thoracic cord, but certainly can involve the cervical cord. And to remember the different metastatic cancers that can cause cord compression, remember lead kettle. And lead here is PB, prostate and breast. So prostate cancer, breast cancer tends to go to the spine. And the kettle is kidney, thyroid, and lymphoreticulae. Okay, so those would be the 5 common metastatic cancers that tend to involve the cord. So, for example, you have someone that presents with a rather subacute over weeks of progressive spastic weakness. You've localized it perhaps to the thoracic or cervical cord. That would be a medical emergency to image that area of the spine and find out if it's a metastatic cancer, get the patient on steroids, perhaps surgery, radiation treatment, and so on. All right, so our first spinal cord condition here is compressive myelopathy. Second, which we won't say a lot about, is due to acute spinal cord trauma. And this typically occurs from motor vehicle or motorcycle accidents or sports-related, football, diving accidents. And so far and away, the common population for this is men in their 20s and 30s. And so there are certain areas of the spine that are more susceptible to injury, and those tend to be areas of mobility around areas of stability. So for example, low cervical, or thoracolumbar, or lumbosacral. And so these patients typically present with paraplegia, and again, that may be complete paralysis, it may be partial, could be a Brown-Séquard syndrome where one leg is weak, the other leg is numb. But it's very obvious related to some sort of trauma, and you want to localize that lesion and then do appropriate imaging. And typically we'll put these patients on high-dose steroids because that's of proven efficacy. So again, the major manifestation there is weakness. Sure, they're going to have sensory involvement, okay, but that's of relatively little concern compared to the fact that they can't move their legs, typically. Okay, now a non-traumatic cause would be transverse myelitis. Okay, later on we'll talk about multiple sclerosis, but multiple sclerosis is certainly the most common cause of transverse myelitis. And typically there's inflammation in the spinal cord that may be partial, may be complete, and patients tend to present with progressive weakness, usually that is maximal within about 24 hours. So we'd want to think about this certainly. Remember, MS is a condition of young people. So if you have someone in their 20s and 30s coming down with rapidly progressive over hours leg weakness, that would be a pretty good story for multiple sclerosis. One other thing to mention here about transverse myelitis, remember the pain and temperature pathway that crosses here. I'm just going to draw this here coming from the other side because multiple sclerosis tends to involve here the crossing pain and temperature fibers, and that tends to produce at the level of the lesion a feeling of a tight band. So if it's in the thoracic area, patients will have a feeling of a tight band that's being pulled across the chest or the abdomen area, and that's a very common symptom that we see with transverse myelitis. Okay, we'll come back to MS later. Another condition that presents mainly with motor manifestations is AIDS myelopathy. Okay, we have a more expanded discussion on that during our lecture on neurologic complications of AIDS. But this is in someone, not a new diagnosis, but this is someone who's known to be HIV positive. It's a late manifestation. And these patients present with progressive spastic weakness. and typically with some posterior column involvement as well. And in that lecture, we talk about it's a diagnosis of exclusion, so you want to make sure there isn't some mass or something else that's compressing the spinal cord. But if we image the spinal cord, typically we see some signal changes in the thoracic or perhaps cervical cord. Okay, and then we have an infarction of the spinal cord. Remember the vascular anatomy. The anterior spinal artery supplies the anterior 2/3 of the spinal cord. The posterior spinal artery supplies the posterior columns. So if we have an infarct involving the anterior spinal artery, that's going to come on suddenly. Remember, that's the hallmark of any vascular process, sudden onset problems. And so of the pathways we've talked about here, if we have an anterior spinal artery infarct, the patient is going to have bilateral weakness below the level of the lesion, and they're going to have bilateral loss of pain and temperature below the level of the lesion. But the classic thing in that condition is the posterior columns, because it's a different blood vessel, are preserved. So you get out your tuning fork, you check proprioception by moving the toe up and down, and it's entirely normal. All right, so it's profound weakness, pain and temperature loss, but preserved vibration and proprioception. Now, in the real world, it's usually not that easy, because who gets infarctions of the anterior spinal artery? It tends to be patients that have diabetes. What do patients with diabetes have? They often have peripheral neuropathy. So they have some loss of vibration and proprioception from peripheral neuropathy. So sometimes it's not that easy to sort this out. Now, what area of the cord tends to be involved? It's mainly thoracic. Remember, we mentioned that the vascular supply to the spinal cord is via about 8 or 9 radicular arteries that boost blood supply to the spinal cord along its course. And that a very large radicular artery is called the artery of Adam-Kavitz. And this artery supplies a thoracic cord such that there's a watershed area, lower thoracic cord, upper lumbar cord, so that above that, mid-thoracic, upper thoracic, there's an area of relatively precarious blood supply. Okay, and so most of these infarcts tend to occur in mid or upper thoracic cord because of that artery of Adam-Kavitz. Okay, so those are about 5 conditions that tend to involve or present with predominantly weakness. Okay, that's of an upper motor neuron variety. Now, the next category here will be weakness that presents mainly in the lower motor neuron distribution. And we won't say much about this. I'll draw a few lower motor neurons or anterior horn cells here, but polio would be our classic condition that presents mainly with lower motor neuron weakness. Now, we don't see very many patients with polio, although we did have a patient a number of years ago who was not immunized from Mexico that had polio, but still it's quite rare. Polio used to be the most common cause of an acute flaccid paralysis. But yet you'll see a number of older individuals typically that had polio when they were kids. And the story is usually the patient was sick, they had some sort of a viral meningitis, and in that context they developed weakness. And so this tends to be asymmetrical, but it involves the anterior horn cells. So it may be one leg, maybe both legs, maybe one side of the body more than the other. Okay? But patients have weakness, and when you examine them even decades later, what you're going to find is they have weakness in whatever anterior horn cell distribution was involved. And since these are lower motor neurons, let's just say we had a patient with polio that mainly involved the L2, 3, 4 lower motor neurons. Okay, well, that patient's going to have proximal leg weakness. You're going to look at the muscles. They're atrophic because it's lower motor neuron. You check the patellar reflex. It's going to be absent compared to the other side. All right, but this is a pure lower motor neuron problem. In other words, the sensory nerves are fine. So get out your pinprick, check vibration, proprioception. It's entirely normal. Pure lower motor neuron weakness. Okay, and lastly, what have we said is the hallmark of any lower motor neuron condition? It's fasciculations. So even decades later, we'll see these little twitches and ripples in the involved muscle known as fasciculations, classic for anterior horn cell disease. Okay, now let's spend some time talking about now a myelopathy, if we call it that, that presents with mixed upper and lower motor neuron findings. And I'm going to erase this, but before I do, let me just show you anatomically, if we're just thinking about the spinal cord, where this occurs. And of course, the condition we're talking about here is ALS, or Lou Gehrig's disease. ALS is a motor neuron disease, okay, but it's upper and lower motor neurons. So if we're just looking here at a section of the cord, what we have is degeneration of the upper motor neuron pathway, the corticospinal tract, okay, and we have degeneration of the lower motor neurons here in the ventral horn. Okay, so both the upper and lower motor neurons degenerate. That's why this is such a devastating condition, because the nervous system takes a double hit, really, both upper and lower motor neurons. Now, this is not entirely correct, however, in the sense that this is not a demyelinating disease. Okay, the reason the corticospinal tract degenerates is because the problem is up at the cortical level. Okay, the motor neurons in the brain are degenerating. And as they die, the corticospinal tract, the pathway that originates from that area, degenerates. So the problem is really cortex in the brain, motor neurons, and lower motor neurons in the spinal cord. So ALS tends to present with weakness. So about a third of patients present with a foot drop, about a third of patients present with hand or arm weakness, and about 20% will present with weakness of talking and swallowing muscles. So patients present with dysarthria and dysphagia. Typically, ALS has onset between the age of 55 and 75, although it's thought that a lot of the elderly population were probably just not diagnosed. All right, so grandpa in his 90s passed away rather quickly over a 4-month period of time. Well, he was just old. Well, maybe he had ALS, and we're just missing some of those older individuals that had this condition. Let me draw out here a little bit of these connections between the cortex and the brainstem so that we can illustrate some of the talking and swallowing problems these patients have. Okay, and in the medulla, there are two very important areas for swallowing. One is the nucleus ambiguus, and the other is the hypoglossal nucleus, of course, for movement of the tongue. Okay, and the pathway that communicates with this is known as the cortical bulbar tract. Okay, and recall that the cortical bulbar tract, here I'll just write CBT, for the most part is crossed and uncrossed. So it talks to nucleus ambiguus hypoglossal on the same side, and it crosses over and talks to the nucleus on the other side. Okay, so the cortical bulbar tract is an upper motor neuron. ALS is an upper motor neuron condition. So we have degeneration of the cortical bulbar tract up here, so that the upper motor neurons are not communicating appropriately with nucleus ambiguus, which is motor nucleus for 9 and 10, and the hypoglossal nucleus. So patients present with dysarthria, dysphagia. And typically, if the lesion is up here at the cortical bulbar tract, they have what's known as emotional incontinence. They can't control their emotions. Something not so happy, or something, they're watching something on TV, it's really not that funny, and they giggle uncontrollably. Or something happens, it's not that sad, and they just burst into tears. Okay, so if you hear that story, you want to think about a lesion up here of the cortical bulbar tract. And this constellation of dysarthria, dysphagia, and emotional incontinence is known as pseudobulbar palsy. And ALS is one of several different things that can cause pseudobulbar palsy. But pseudobulbar palsy is anything that involves a lot of the cortical bulbar tract. Could be ALS, a bad case of multiple sclerosis could certainly do this, or a patient who's had lots and lots of subcortical strokes. Okay, we'll talk about both of those conditions later. Okay, so ALS can present with pseudobulbar palsy, but remember ALS also involves the lower motor neurons. And these are lower motor neurons, nucleus ambiguus and hypoglossal nucleus. So the lesion can also occur of the lower motor neurons in the brainstem. And so if the degeneration starts in the brainstem, we call this a bulbar palsy. Again, patients present with dysarthria, dysphagia. Okay, they don't tend to have the emotional incontinence, however, like we'd see with a pseudo-bulbar palsy. How can you distinguish the difference between the two? Well, again, one is we don't have the emotional incontinence, but if you just look at the tongue, for example, if this is a bulbar palsy, the degeneration is occurring in the bulb, the tongue is going to be atrophic, atrophied. You'll see fasciculations in the tongue. All right, so usually we can distinguish between the two, but of course, over time, you'll get both upper and lower motor neuron involvement, again, the double hit, and that's why this form of ALS that tends to start early with talking and swallowing is so devastating. Okay, so one other interesting thing about ALS, so the patients are getting weak all over, arms, legs, talking and swallowing muscles, but the degeneration, for whatever reason, tends to stop at about the mid-pons. Okay, so that most of the manifestations in terms of brainstem involvement for ALS are talking and swallowing. Eye movements, for example, are relatively preserved until very, very late with ALS. I saw one patient who was a judge who was completely paralyzed, couldn't talk or swallow, was on a ventilator to breathe, but could still use his eyes to do things on his computer, even to do some legal work. Okay, so eye movements tend to be relatively preserved in ALS. Other things that tend to be relatively preserved. Cognition. Now recently there has been some evidence of dementia in ALS, but it's relatively minor clinically compared to the very dramatic motor manifestation. Something else relatively preserved, bowel and bladder function. Okay, those motor neurons are preserved. And finally, the sensory nerves. There may be some mild subclinical involvement, but for the most part, this is weakness. Patient is paralyzed eventually, but they can feel everything just normally. So most patients die within 3 to 4 years of the onset of symptoms. If patients present with bulbar onset ALS, prognosis is very poor, 9 to 12 months typically. And death is usually due to respiratory failure. You should know that about 5 to 10% of ALS cases are known as familial ALS. Usually these are autosomal dominant. And so patients present with a family history that's very obvious. And there is an association there with superoxide dismutase gene, a mutation in a number of cases of familial ALS.